Thank you so much for this kind invitation. I wish I could be there in person. Right now, I'm presenting to you virtually from Boston. Tamara and Carl asked me to talk on evidence supporting PK-Activators and really the update on the data, which, this is obviously a very exciting time in the treatment of PK deficiency. Recently, just earlier this year, got the first FDA-approved drug. I know Dr. Grace, who went before me, likely touched on some of the data for Mitapivat. So I apologize if there's some repeat here, but it's all good data. Here are my disclosures. So I know the audience is probably familiar with PK activation or PK activators in general, but just to review this briefly. So pyruvate kinase is a very important enzyme in the production of energy in cells, and in particular in the red blood cells, which cannot use oxygen to create energy. And so they are highly dependent on the amount of energy produced by what's called the glycolytic pathway. And pyruvate kinase produces half of the energy out of that pathway. And so when pyruvate kinase is deficient, as we know, we have reduced energy in red blood cells, and the red blood cells are less able to maintain their membranes and their normal lifespan. They break up prematurely, as we call hemolysis. And pyruvate kinase activators are medications that sort of latch to the pyruvate kinase enzyme and they rev it up. They increase the energy output from the enzyme. They make the enzyme more able to convert phosphoenolpyruvate, the prior compound, into pyruvate and produce energy or ATP in the process. And there are three pyruvate kinase activators that I will mention briefly today. One I'll mention quite a lot, which is Mitapivat, which is what we have the vast majority of the data on. Mitapivat is another pyruvate kinase activator in development, as is a drug called AG946. And so when we have pyruvate kinase deficiency, which is what we're talking about today, obviously we have a less energy than we need. We have a normal demand for energy in terms of the red blood cell, but the production is reduced. In some other diseases, in some of these PK activators, for example, Mitapivat and AG946 are not currently being developed in PK deficiency. They're being developed in other diseases. But in other diseases, the demand is higher than what's being produced. And what's being produced is normal or near normal, but it's just that the demand is much higher. So I'm going to focus on data for PK deficiency. Obviously, that's the what we're focusing on here today. But I also I include a little bit of the data from thalassemia being kind of a brother disease to PK deficiency. I think more data is always interesting and helpful in terms of understanding these drugs. So Mitapivat is a first-in-class, meaning the very first drug being developed that was developed as a PK activator in the class PK activators. First-in-class oral allosteric activator of pyruvate kinase. So again, allosteric meaning it latches on to the pyruvate kinase enzyme and it changes the way that the enzyme is shaped in such a fashion that improves the activity of the enzyme. This drug, as we know, is FDA approved for PK deficiency and currently investigational for a few other diseases that it's being tried in. It's a potent activator of both wild type or normal pyruvate kinase enzyme, as well as a wide range of mutant enzymes. PK deficiency is characterized by over 350 different genetic mutations that we know cause disease, and probably many more that we have not yet characterized. And so these compounds, and Mitapivat in particular, has the ability to bind to the enzyme, many different kinds of enzyme, not every kind of abnormal enzyme, but many different kinds of abnormal enzyme, and rev them up and increase the production of ATP or energy. So in a phase 1 study, which 48 healthy volunteers received Mitapivat or placebo for up to 2 weeks, the optimal dose was defined. There were no major adverse events or really major problems with use of the drug, and in some cases in much higher doses than we use in PK deficiency. In the phase 2 study called Drive PK, This study assessed the efficacy and safety of Mitapivat in 52 patients with PKD. The study was led by Dr. Grace, who just spoke to you earlier. The mean peak hemoglobin rise in those patients who responded was 3.4 grams per deciliter, and about 50% of patients had a response of greater than 1 gram per deciliter in hemoglobin. Most common side effects noted were relatively minor: headache, and insomnia, nausea, common cold, joint pains, and were not of high grade. In other words, they were not severe side effects. I'll show you some data regarding how patients responded based on their underlying genotype, their specific mutations. In PK deficiency, we classify mutations very generally into one of two groups, either a missense mutation or a non-missense mutation. Missense mutations are a change in one amino acid for another that doesn't cause the protein to stop prematurely and basically be a partial protein rather than a full protein. That one mutation can certainly change the function of the protein and cause the protein to not work very well, but you still have a protein. Non-missense mutations come in all sorts of different kinds, including mutations that create a truncated or a partial protein. And so it was recognized that if you have missense mutations, you're more likely to respond to Mitapivat. To the tune of, in the DRIVE PK study, there were no patients that had two non-missense mutations that ended up responding, whereas there were a number of patients that had one missense and one non-missense mutation that did respond. So this slide shows the impact of the baseline pyruvate kinase erythrocyte or PKR protein level on the likelihood of response or lack thereof. And the more protein you have around, the better, very simply. Now, there are some patients that had high protein levels that were very non-functional protein or protein that could not be revved up by the enzyme. But the more protein you have around, the more likely you are to respond to Mitapivat. This is not a test that we do typically in the clinic, but it just helps us understand. It fits very much with the mechanism of the drug. So the phase 3 study was there are two phase 3 studies that were the follow-up to the DRIVE PK study. Activate was the first. This was a phase 3 global randomized double-blind placebo-controlled study of 80 patients with pyruvate kinase deficiency not receiving regular transfusions. And patients were randomized, meaning there was a 50% chance they got placebo, 50% chance they got active drug, Mitapivat. This was adults, people who are 18 years or over, that had a clear genetically proven pyruvate kinase deficiency and a hemoglobin less than 10. And so there was a 12-week individualized dose escalation period, and then a fixed dose period in which the quote unquote optimal dose for that patient was continued for 12 more weeks. And then people could enter an open label extension study, which is ongoing to this day. So 80 people entered the study, were randomized, 40 randomized to receive Mitapivat, 40 randomized to receive placebo. Every patient randomized to Mitapivat ultimately received treatment with Mitapivat. One patient randomized to the placebo arm withdrew from the study before their first dose of placebo. And again, people did not know what they were receiving. That's what double blind is. The patients did not know what drug they were getting. The doctors did not know what drug the patient was getting. And this was the main result. So we see here, this is what's called a waterfall plot. It looks like a waterfall. Each line here, each bar is a patient, and it shows what their change in hemoglobin was from the beginning of the study to the average of hemoglobin measured in the fixed dose period. All right, so the second 12 weeks of the study. And we see that there was a range of, in patients receiving Mitapivat, patients improved their hemoglobin by up to 6 grams. 6 gram improvement, 5 gram improvement, 4 gram improvement. The threshold for a response was at least 1.5 gram improvement or higher. So it was a higher threshold than the DRIVE PK study. And 40% of patients randomized to receive Mitapivat reached that higher bar, that threshold. We see that there were the patients in green, the green bars here were non-responders according to that 1.5 gram, but we see that even the non-responders in the Mitapivat arm did better than most of the patients in the placebo arm. So we have to pick a threshold for response, and that threshold should be rigorous and meaningful. But most patients receiving Mitapivat did have improvements in their hemoglobin. This is just another way of looking at the same data, except it's the mean hemoglobin for the entire group, the entire 40 patients receiving Mitapivat and the entire 40 patients receiving placebo. And it looks at the change in the hemoglobin from baseline, the beginning of the study, to that fixed dose period. And we see here again, rapid improvement over the first several weeks of that dose escalation period. Most patients needed 50 milligrams twice daily. This drug is started at 5 milligrams twice daily, but very few patients respond to that. And then a few more respond to 20, but most people need 50, like the vast majority. Ultimately, 88% of patients were escalated all the way up to 50 milligrams twice daily. This table shows all of the other, what are called secondary endpoints in the study, meaning the other things that were looked at that are clinically meaningful to show that this drug works or doesn't work. And all of these things improved significantly in the Mitapivat group over the placebo group. These are markers of blood breakdown or hemolysis, things like haptoglobin and LDH, indirect bilirubin. Bilirubin being the thing that makes people's skin yellow tinged, right? Causes what we call jaundice. All of these things improved substantially, and the study actually met every single secondary efficacy endpoint. So it's pretty rare for a study to do that. So it was pretty clear that this drug was effective. There are also two health-related quality of life measures that are pyruvate kinase deficiency specific, called the PK-DD, pyruvate kinase deficiency diary, and the PK-DIA, or pyruvate kinase deficiency impact assessment. These were what we call patient-reported outcome measures, or surveys the patients were taking over the course of the study, and they improved significantly higher in the Mitapivat group than the placebo group. This just shows graphically. The blue bar is the patients receiving Mitapivat, and the gray bar is the patients receiving placebo. And lower for these things is better. These are the markers of blood breakdown or hemolysis, indirect bilirubin on the left, and then LDH on the right. And then haptoglobin, we want to go up, and the patients in the Mitapivat arm had improvement in the haptoglobin, and reticulocyte percentage, we want to go down, representative of the blood cells living for longer, and that clearly went down in the Mitapivat group and did not change in the placebo group. Now, safety is critical, right? A drug can be as effective as anything, but if it's not safe, then who wants to be on that unsafe drug? And Mitapivat was found to be safe. In fact, the rate of what are TEAEs, or treatment emergent adverse events, essentially any side effect reported by a patient on the study in the Mitapivat group, was almost exactly the same as the placebo group. When we look at these adverse events that led to dose reduction of the study drug, interruption of the study drug, discontinuation of the study drug, or death, we have zeros through the entire Mitapivat group. So not a single patient ever had a side effect that required them to have a dose reduction or interruption of their Mitapivat. Those patients in the placebo group, and remember, the doctors did not know what the patients were getting. The patients did not know what the patients were getting. There were 2 patients on placebo that did have an interruption of receiving placebo due to a side effect that was thought to potentially be related to the placebo, the study drug. They didn't know it was placebo. They just knew it was study drug. When we look at the actual specific events that were reported, the most common side effects were reported that in the patients receiving Mitapivat that reported were nausea, headache, and nasopharyngitis, or basically an upper respiratory infection or cold. And we see that actually all 3 of these were more commonly reported in patients receiving placebo. So 7 patients for nausea with Mitapivat, 9 for placebo, 6 patients had headache in the Mitapivat group, 13 in the placebo arm. And so this is why we do randomized trials, right? Why things are double blind, because this really lets us say, okay, all of those side effects that were seen in the DRIVE PK study that were reported in patients receiving Mitapivat, how many of these things are really related to Mitapivat? If people don't know what they're receiving and we're still collecting all the side effects, when we see an outcome like this, we're very heartened. We say, wow, this profile is really quite similar overall to placebo, which is good. That suggests to us that the drug is likely very safe. And just one other thing here, we do grade the various adverse events, and there were 3 grade 3 or higher adverse events in the mitapivat arm, and grade 3 or higher is essentially significant adverse events. And only one of these was thought to be related to mitapivat musculoskeletal pain. And then if we look again here, musculoskeletal pain is not a common thing that's been reported, that was noted in patients receiving mitapivat generally, and not something we've seen beyond the study. So it's, again, very heartening. We look at the health-related quality of life, and we see that in patients receiving mitapivat, which is the blue line, the severity of their PK deficiency as reported by the patients went down. So lower is better in this graph, and we see the gray line is placebo, the blue line is mitapivat, and the orange line are responders. So those patients who are on mitapivat who had a response, and they have by far the greatest improvement. This improvement is about twofold the what's called the minimal clinically important difference in these patient-reported outcome measures. And the same thing for the pyruvate kinase deficiency impact assessment. So the daily diary is something that assesses symptoms on a daily level, and the impact assessment is something that's a more global assessment of how the disease is impacting the person. And we see that again, the mitapivat group did better, and the mitapivat responders did a whole lot better. We see here from the long-term extension study, when patients on placebo cross over to mitapivat, that they have essentially they gain the exact same improvement that the patients that were started on mitapivat had, and you see the gray line move up and start meeting where the blue line is, and then that stays stable. This is the hemoglobin. Many patients on mitapivat achieved a normal hemoglobin. So for patients that have not had a splenectomy, which causes changes in the blood counts, when you go on mitapivat and you achieve your hemoglobin comes up, you have patients that have normal blood counts, normal CBCs. There's no way you could tell they had any sort of disease just by looking at their CBC. All their labs become stone cold normal, and so in many patients receiving mitapivat, here, they had normal hemoglobins at least once. So this is 26 patients that had normal hemoglobins at least once. The yellow lines are patients that had hemoglobin persistently, never lost that response. And then the gray lines are people that kind of dip slightly below normal and then above normal, and so on and so forth. But these are all people who obviously responded very nicely. Something that's really important is not just improvement in hemoglobin, right, but also improvement or prevention of long-term consequences of hemolytic anemia, of hemolysis, things like iron overload. Iron overload is a very, very concerning problem in PK deficiency that can lead to liver cirrhosis, liver failure, liver cancer, heart failure, death, all sorts of bad things. And so one thing that was recognized, and this is a complicated slide, but I'll interpret it for you, basically to say that the proteins that we measure that are involved in iron metabolism got better in patients receiving mitapivat, and they did not get better in patients receiving placebo. And then when the placebo patients crossed over to receive mitapivat in the open label extension, their iron metabolic proteins got better. And liver iron concentration, or LIC, when you get an MRI of your liver, that's assessing the iron concentration in your liver. And the patients treated with mitapivat had improvements in the liver iron concentration. And so this is really heartening, right? Because normally we need iron chelation to improve iron levels in the liver. And it looks like that patients treated with mitapivat who have PK deficiency can potentially achieve what we call a negative iron balance, in which their iron levels are actually improving just from normalization of their hemolytic anemia or reduction in their hemolytic anemia. Bone problems and bony disease is also a major problem. Up to 75% of patients with PK deficiency develop low bone density by the mid-30s on average of age. And so, we monitor bone density in PK deficiency, and we want to make sure that if it needs to be treated we have to treat osteoporosis, that we will do that. But we monitor bone density in patients receiving mitapivat as well. One of the off-target effects of mitapivat is called aromatase inhibition, and that could potentially have an impact on bone density. And so it was very important to monitor this on the clinical trial. And we did, and patients from Drive PK Activate and the Activate T study, which is the transfusion dependent study I'll mention in a moment, over time, we actually see that the vast majority of people have stable bone density. Only a few ultimately had worsened bone density, and only a few had improved bone density. But stability is a win, and if we're able to arrest bone density loss, that is certainly a good thing. So we did not see that this drug caused a reduction in bone density, and in fact, it seems to help stabilize in many people. Activate T was the other phase 3 study. This was looking at patients who were regularly transfused, received 6 or more transfusion events in the prior year. And this was not a randomized study. So only one treatment arm, everybody on the study got active drug. And this study was also successful, with 30% of patients achieving a 33% or more reduction in transfusion burden. And Mitapivat overall was well tolerated. There are actually transfusion-free responders. So there were folks in this study who were getting regularly transfused. They went on Mitapivat. Not only did they reduce their transfusion burden, but they actually stopped needing any transfusions. And some of these patients even normalized their hemoglobin. So to go from having regular transfusions to not only not needing them, but even having a normal hemoglobin is obviously an incredible response. And again, like Activate, the side effects noted of the drug in this study were not significantly, the side effect profile was similar to prior studies. There were not new safety signals or concerning issues found. So just in the last few minutes, and I want to make sure we have time for Q&A here, in the last few minutes, just briefly mention some of the other data and other diseases. And, you may think, why does it matter, data in thalassemia? Well, the diseases are similar in a lot of ways, and also more data is just good to have, right? More safety data. It's good to know if a drug is effective in other diseases as well. And so in a phase 2 study completed in patients with thalassemia, related blood disease, receiving Mitapivat, this was a study that had 24 weeks, what called core period, and then extension study, just like with Activate. This was not randomized. Everybody in the study received the active drug. There was 80% of patients that achieved the response of 1 gram of hemoglobin improvement or greater. And that was seen in both patients who have alpha thalassemia and beta thalassemia, 2 different kinds of thalassemia. And the average improvement in hemoglobin, not quite as high in PK deficiency, but around 1.2, 1.3 grams. Again, with some patients achieving a higher increase as high as 3 grams. So, the hemoglobin improvement achieved, again, was patients rapidly improved their hemoglobin, and that improvement was sustained, just like in PK deficiency. And looking at the long-term extension period, again, improvement sustained. So, we want this drug not only to work, but also to that improvement to be maintained over time, right? We don't want to lose responses, and we don't lose responses. Just like with Mitapivat and PK deficiency, there was a reduction in many of these markers of blood cell breakdown and what we call hemolysis, as well as hematopoiesis, production of red blood cells, exactly the way we would want them to be. And bone mineral density also remained stable. Patients with thalassemia, just like PK deficiency, develop brittle bones. And we were very happy to see in this study, all these lines be very close to just straight lines, right? Things are not trending downward on the whole. So the Mitapivat is now also in clinical trials for sickle cell disease, congenital dyserythropoietic anemia, hereditary spherocytosis, some of these other rare blood disorders that are all in this family that PK deficiency is in. So very happy to see additional data. Sorry, that's my pager. Very happy to see additional data come in as these studies are completed. So happy to answer questions.